Morning. Sorry, I reached late. So thank you for calling me here. It's a pleasure. And I must acknowledge the presence of Suhas and Adarsh. I actually went to their center and I learned a few tricks of robotic surgery. I just began only a few months ago. And they said, well, let's have a demo surgery by a demo surgeon also, learner. So you will see that why I got into robotic. I'm grateful to you, Suhas and Adarsh. Very nice of you. So today my brief here is to talk about what I've been passionate before getting into this robotic was mobile partial knee arthroplasty. Now why do that and why not do total knee arthroplasty in the cases that it is indicated? I mean, when we see these two x-rays, I'm sure everybody will agree that they are really apples and oranges. They're not the same. Because if you see this classification by Pravesi et al., now we understand that the medial arthritis is not one entity. There are different types of medial arthritis, and one of them is what is known as anteromedial osteoarthritis, and in which we have anterior cruciate ligament is intact, medial joint is affected, lateral is okay. When there is flexion, there is a bump present on the posterior aspect of tibia. The femur rides on that bump and stretches the anterior cruciate ligament and stretches the medial collateral ligament, doesn't let it shorten. So the important thing is that medial collateral ligament here is not shortened. The lateral compartment is okay, patellofemoral compartment is okay, and many times when you do total knee arthroplasty, you find that ACL is intact. The defect, the impression that you see is only anterior on the medial aspect. So in those cases, would it not be logical to just attend to that and not to fiddle with other things? I remember when in childhood we used to read Reader's Digest, and there was one funny quote in that: when you do my hernia, don't you fiddle with things that don't concern you. So it's something like that. If your other things are not damaged, so why are we fiddling with that? So that is the logic. So if we have a bone-on-bone arthritis on the medial side and ACL and MCL are functionally normal is the buzzword. It's not just normal, but functionally normal. And if the lateral compartment has full thickness cartilage, then really total knee arthroplasty is not required. HTO, as we will see in the next slide, is also not an indication for this type of issue. The indication really here is a unicondylar arthroplasty. And there are methods by doing only plain x-rays in a proper angle and in a proper way to find out whether or not it is anteromedial arthritis. I will not go into the details of that. You can do stress x-rays, varus valgus, lateral view is the most important, and that can tell us whether it is an ACL intact. And when we started doing it, I used to rehearse it in total knee. I used to write on board that this is what I expect. I'll find this. And after a year or so, when our predictability became good, then we started doing uni knee. And still there are surprises. Once or twice a year, you do get a surprise that, well, we thought we'll do uni and you end up doing a total knee. But the surprises are few and far between. So, I mean, this is more on, even clinical is not okay. Just X-rays are fine. MRI is also unreliable. And arthroscopy to, do all these things is really an overkill, unless there is some lateral joint pain and you want to see that lateral meniscus is okay or not. Otherwise, it's not really required. This unicondylar knee arthroplasty did not gain big popularity recently, and before it got into defame for various reasons. And one of the reasons was that it had a lot of challenges to do it. It's not a simple little thing that you go and put in and come out, because every step you are thinking and you are, especially in mobile, you're thinking, oh, I hope it doesn't dislocate. So all these, it's a challenging surgery. It's not like a simple, straightforward thing. And the biggest challenge is finding the right patient. If we do it in the wrong patient, the results are not going to be good. Especially in partial thickness cartilage loss, it has been documented in various studies that the results, for whatever reason, are not good. not as good as, for example, it would be by HTO. So PTCL probably would be the right indication for HTO and would not be an indication for a uni knee. And uni knee should only be done when there is bone on bone arthritis, demonstrated either on a standing X-ray or on a varus stress X-ray. But we must demonstrate bone on bone. And this is the table. There is some little overlap between HTO and uni, but mostly I think if the formula has to be remembered, if it's a cartilage disease, then HTO, and if it is a bone-on-bone disease, then uni. I think that's a simple formula rather than going into any other thing. And you know, the famous paper by Cousin and Scott, there were many contraindications which were thrown out of window in this study of 1,000 cases, where even if there was a patellofemoral joint damage on the medial aspect, age was not a criteria, obesity also was not a criteria, chondrocalcinosis. So mobile bearing knee has a lot wider indications than in the, for example, weight used to be a big criteria in earlier indication. For example, this lady is 103 kilos. She is the wife of a Supreme Court lawyer, and I believe in the concept, and we did it, and she's doing well now. It's about 7-8 years. And her husband, who's a Supreme Court lawyer, also felt very good the way his wife was walking, and he himself came and got a uni done. So weight really is not a criteria. I mean, of course, you're not going to do it in a BMI of 40. I mean, we have to be judicious about it, but generally speaking, we are okay. Similarly, age also is not a criteria. In fact, I'm very fond of doing it in patients who are 75 or 80, but they do fantastically well, because you're doing a small little surgery and their pain is gone and they feel so, I mean, it's really a win-win situation. I mean, you're doing a small surgery and their pain is gone, you have addressed, and you do get AMO even in elderly. One may be surprised why lateral is not, but it's not. There are many cases, and even if there is a little bit of involvement on the lateral side, they do fantastically well. So I'm absolutely convinced that in elderly, if there is an indication, one should not hesitate in doing. Similarly, in younger, it was a contraindication earlier, it's not now. And the funny thing is that the more activity they do, the papers, they say that the more is the longevity. So they probably get set there, or whatever the reason is. There is no need to tell them not to, say, for example, jog, not to play light tennis, etc. So there is no need to do that. And there are papers and papers saying the results are, the survival is good. And revision rate of 2.5% in a young population, I think, is quite acceptable. Extended indication, we talked about SONC, etc. The results are again reported to be good in various papers. Now, ACL deficiency, also, if it is a young patient with significant pain, with medial arthritis, one could reconstruct the ACL and do uni, either in the same sitting or in 2 sittings. I would be afraid of doing in 1 sitting because I think it will be too much. This is not really, I have not understood the logic. See, every time when we are trying to do the Oxford knee or mobile knee, we are told, well, put only 1 pin, don't put 2 pins, be careful of putting pin, this can cause tibial fracture. And here is literature suggesting that you can drill a big tunnel to put that tibial screw, you can do this and that and then do uni. It just doesn't appeal to my common sense. So I personally would never do that. If I have to do it, I will do it in 2 sittings if required, but I haven't done it, to be honest, but I would not do it in 1 sitting. But according to literature, you can do fixed uni even in the presence of, and in US now the trend is they don't bother about ACL because they are not doing mobile and they are doing the fixed bearing, so that is food for thought. Similarly, in recurvatum, I've done a few cases of uni in recurvatum with very mild recurvatum. Otherwise, if it is more than 5 to 10 degrees, then TK is better because there are many manipulations one can do with TKR, which we cannot do it in uni. So that would be it. Obviously, inflammatory arthritis, biarthritis, compartmental arthritis, severe deformities would be contraindications, and we obviously will not venture into those areas. And then the reason, as I said in the beginning, it did not become very popular in the general population of orthopedic surgery, it has a long learning curve. And there are nuances and there are potential problems when you're doing it. For example, there are tricks to be done that don't lift your hand, don't put too many pins, and be careful, make sure there's no impingement, make sure there is. So all these things do come with time. I mean, nothing comes easy. If something has good result, then I don't think one should be afraid of a long learning curve. That cannot be the criteria of not using it often. So these things can be avoided, dislocation, fractures, if one is careful. Occasional problem will happen and we'll have to tackle that. The good news is that because it is part of a sphere, a lot of malalignment is acceptable in these mobile type of bearings, and then they do all right. Again, fixed bearing and mobile bearing, I've just talked about it. Fixed bearing has very narrow indication, mobile has wider indication which can be done, and there are papers after papers saying the results of both are good, but in the lateral uni, one should not do mobile bearing because there is so much of play of that meniscus. The chances of dislocation are high, and in those cases one must do fixed bearing. Again, for uni knees, you can see in every respect, if you compare it with TKA, it does better initially. Length of stay is smaller. The potential complication reported in literature, DVT, infections, CVAs, MIs after surgery, much less. If we do 100 unis where TKA would have been done, it is estimated that we can prevent one death. So that is the potential. In this TopCat study in UK, where they did it in number of centers, the answer was that uni should be the top choice where it is indicated, because the results are either better or at least as good as TKR, with less morbidity, with less bone removed, with all the bone preserved. So I think it's a no-brainer that in such cases there's no question. And see, studies after studies after studies, survival rate 95%, 94% 15 year, even 91% and 20 year in sub-studies. So, and even this in this 15-year follow-up, which is yet in print, it should not be treated as a time-buying operation. As some people, often people who don't do it say, oh, you know, you can buy 5-7 years and then we'll do it totally, and then people get scared. That is not true. It is a definitive answer and it's a definitive option. It will last as long as total knee with bone preserved, with much better function, and people have forgotten knee score will be much higher than otherwise. But the problem is that if people who are not doing enough number, they sometimes give it bad publicity. You see this, the number of revisions, people who are doing either 1, 2 or 3 a year, or those who are doing too many, more than 60-80% of their knees are uni, also their revision is higher, because then they tend to choose cases where they should not be doing uni. So around 40 to 60% of our knee, if we are doing uni, is probably good. And the survival rate is also good. And remember one thing, 20%, why we are talking about robotic is we are trying to answer that 20% unhappy knees. So those unhappy 20% knee, nobody revises. A little bit of, problem with uni, people are ready to revise. So that's one big reason why people tend to revise unis faster, and they are also younger people. So we now have to take the whole thing into perspective and then take a call on this. In my opinion, even these registries, a New Zealand registry where it was given bad press, they had taken cases from centers where they were doing 2, 3, 4 cases a year. So that cannot be, we are comparing apples with oranges. So I think, and now Dr. Robert is here. He is going to help us even with uni, and Suhas and others. I think they are going to show one today. But that's a fixed bearing, but so be it. The results of fixed are as good as mobile. The idea is the concept, where not to do total knee. And in this study, and even Suhas and Gurva Reddy, and in their center also, and in this UK study also, it has been estimated that about 47% of patients who are offered total knee replacement do as well or probably better with uni knee. So I don't think there is an argument here. I think it's a no-brainer. So really, the sooner we start taking up this, everybody starts taking, the better, because let's not try to kill the fly with a cannon. Thank you for your attention.
One or two question only. So you said bone-on-bone medial compartment isolated is contraindication for STO. But if this bone-on-bone medial compartment OA associated with severe varus deformity, again a genuine indication for high tibial osteotomy. And other thing about the MRI, you are going for X-ray, extending, plain AP, long leg film at the same time. So many a time in this type of cases, there is ACL is also a cause of pain because this is the mycoid degeneration, hypertrophied ciliary tract view of the ACL in the MRI. So nothing wrong in going MRI if you are going for uni compartment osteoarthritis because many a time the pain is not totally because of the medial compartment OA.
I think I'll answer the second part first because I have forgotten the first question. The second part is that yes, various things can give rise to pain, but if there is an obvious cause looking at in our face with medial arthritis, and many a time the ACL is not normal. In fact, most often it is grade 1, 2, 3. And so
Mycoid-
that's acceptable.
Yeah, mycoid
So
degeneration.
it has to be functionally normal. So in those cases, I don't think there is a debate. And as far as MRI to diagnose, I think MRI overdiagnoses. That is the problem. And it gives you, there are many cases which are suitable for uni and you will not do it if you look at the MRI. Because we are looking for functionally normal ACL. We are not looking for a totally normal. And the way the reports come and the way we report. So it's really, I mean, at least I don't do it. If there is lateral joint tenderness which is significant and X-ray is showing good thickness, cartilage, then I would do MRI to see the state of the lateral meniscus. That if it is torn or not, that is a cause of pain. At least in my practice, that's what I do. And that's what is taught by the Oxford group also.
Any question from the audience? My question, sir, the indication for uni or high tibial osteotomy almost the same. So how can you assess which case is suitable for uni and which case suitable for HDO? What is the, on the basis of your clinical or any radiological?
I think this is slightly, we may not agree on this because I don't personally think that the indications for HTO and uni are same. They are actually entirely different. As I said, if it is a cartilage disease, HTO, active, heavy working person, HTO, in a cartilage to cartilage disease. In a bone disease, HTO is not good. Yes, even in those cases, HTO will give relief. But for some time, because I've done HTO, I've seen in medical college when I was a student, we used to do HTO even in some people coming from remote villages and all with severe medial compartment, some other, and they also did well because alignment is changed. So they do get some relief, but that in today's day and age, that cannot be an ideal indication for HTO. So cartilage disease, HTO, and bone disease, that would be the dictum.
Maybe the isolated medial compartment osteoarthritis without any varus deformity. In that case, you cannot do HTO. That is the genuine case for unicompartment osteoarthritis. There is no varus, so no need for high tibial osteotomy. Unicompartment is perfect for that.
Yeah, I mean, varus not more than 10 degrees. So,
Yes.
I agree with your concept about the ACLs being abnormal in MRI frequently. In fact, I think in an older population, it's the norm to have ACL signal that's abnormal. But in my sports medicine practice, the incidence of partial ACLs on MRI turning into full thickness ACLs are almost none. So there's not a direct correlation between partial ACL tears diagnosed on MRI and clinically insufficient ACL. So I think that bears out your point well. I don't understand the concept of looking at cartilage in the surgery or on MRI or Rosenberg views, so to speak, with a flex knee, shooting it from the back to bring out the cartilage wear immediately otherwise. Because to me, if you clinically are demonstrating pain in the opposite compartment before surgery, it doesn't matter to me much what the MRI says or what the x-ray says. If they're already having pain with valgus force on their knee or a squat anteriorly, then probably doesn't really matter what your imaging says. We have to still look at our patients and make clinical diagnoses even though
Absolutely.
there's imaging.
I think you summed up my talk.
Thank you, sir.
Thank you. Thanks a lot.
And I would like to invite our next speaker,